Welcome to this edition of AFMC
I'll tell you how I got better. I'm
glad to be here.
But a mission to
Delivery.
improve.
Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Talayia Johnson, and she is the Dean of the School of Science, Math, and Allied Health at Pulaski Technical College. Talayia, thanks for joining us.
Absolutely. Thank you for having me.
So we're talking about careers in the medical field and a lot of the different programs that Pulaski Tech offers and some changes that you're seeing. Tell me a little bit about the program there.
Okay, excellent. And so, as you stated, I am the Dean of Science, Math, and Allied Health, and we have several allied health programs here at our school. We have Health Information Technology, that is like the computer science of healthcare. We have surgical technology, we have emergency medical sciences, we have respiratory therapy, dental assisting, and nursing. And that includes our practical nursing program, our certified nursing assistant program, and our medication aid or medication assistant program as well. So we have several opportunities in the healthcare field.
And what does enrollment look like? You know, a lot of the conversation with you today spurred from they're saying a lack of employed healthcare workers in these fields. Are you seeing that? Is it trickling down into your enrollment?
Absolutely, absolutely. So there is a shortage of healthcare, and there's been a shortage for quite some time. However, COVID potentiated that shortage, of course, as you know. We have shortages in several of our different areas, from coders to surgical technology, and of course, nursing. There's a huge shortage.
So let's talk about your health information technology program. You are looking to grow it. What is that?
Yes, so health information technology, like I said, it's like the computer science of healthcare. They work in several areas of the hospital, patient access, privacy, scheduling. They do lots of different areas in the hospital, and they are very much in short supply. One of our other areas that's included in health information technology is coding. And, there's a huge shortage of coders. And we just created a technical certificate in professional medical coding that we're looking to grow in order to help mitigate that shortage. But in the state of Arkansas, there's only like 5 certified tumor registrars in the state, and that is a coding type position. And so there are several shortages in that area.
Wow, only 10 in the entire state. So, and that job is in demand.
Yes, absolutely. It's in demand.
And so what type, is it an online program? Is it something that can be done at home, remote, or is it all in person?
Yes, so our health information technology program is a fully online program. It can be completed fully online. And so a lot of our students who are in that program are students who they want to do healthcare, they want to help people, but they don't want to touch patients, right? So they want to do something where they can help people, but allows them a little more flexibility, and that's something that this degree allows for students. This credential allows for students to have that flexibility, both in education and in the workforce. Right. So our program is fully online. And then we have lots of people who work remotely who work in this area of healthcare.
And there's a shortage of surgical technologists as well. Tell me a little bit about that program.
Yes. So surgical technology, those are the people who assist the surgeons in surgery. And so, yes, there is a shortage of surgical technologists in our state. Several of the hospitals reach out periodically to see, who do we have that's getting ready to graduate? Is there someone that they can reach out to sometimes even before they graduate to start the interviewing process? And so they are definitely an in demand job.
And we've had past episodes that talked about a shortage of EMT and paramedics and healthcare emergency workers within communities in the state. And you also offer EMT and paramedic programming as well.
Absolutely. We have an emergency medical sciences program, and that includes our EMT program, which is one semester. So they can come in one semester. It's offered fall, spring, and summer. It's a one semester course. And then once that semester is over, they can get their certification and work as an emergency medical technician. And then also included in EMS is our paramedic program. And our paramedic program is a technical certificate, which takes about a year. And they can also get national registry as well as Arkansas licensure. And then they also have the possibility of securing an associate degree if they, so desire.
And there's some partnerships that you guys have with some of the rural fire departments. There's some credentialing happening with that as well.
Absolutely. So we have a really good partnership with our Arch Street Fire Department. They actually do our extrication training for our program. And then there are several other fire departments as well who they send us their volunteer firefighters, and we provide the EMT and paramedic training for those volunteer firefighters. Yes.
What a really rewarding partnership that helps communities and your program.
Absolutely. It changes the community. It benefits everyone in the community because those volunteers now have the credentials to save people's lives and to intervene in emergent situations and circumstances that benefits the community.
Outside of specifically dealing with rural fire departments, do you see a trickle down in socioeconomic change for rural communities with these programs?
Absolutely. These programs, they change people's lives, Robin. People come to us from various socioeconomic circumstances, and within sometimes 8 weeks, we have programs that are 8 weeks long. Our CNA program, our medication assistant program, those are 8 weeks long. Up through a year, they can totally change their lives with these programs.
And that was my next question, was to ask you about the CNA and medical assistance programs. How are they different than the other ones that you've mentioned?
Yes. So, like I said, CNA and medication assistant, they're both 8 weeks. In order to be a CNA, you just have to basically apply to the program and complete your developmental courses. But that's the only prerequisites for that program. And then for the medication assistant, it's also 8 weeks, but you have to work as a CNA for a year prior to applying to the medication assistant program. But we have several long-term care facilities who are helping to mitigate their nursing shortages with our medication aids and our medication assistant programs.
Do they provide a stackable alternative to where they can kind of build upon each other?
Yes, we have several stackable credentials for lots of our programs. So like for HIT, we have stackable, we have a CP, we have a TC, and then of course an associate degree. For emergency medical sciences, same thing. The EMT is a CP or a certificate of proficiency. And then the paramedic is a technical certificate with the option for an associate degree. The CNA program, the nursing programs, CNA is stackable with technical certificate in practical nursing.
So many options, for sure.
Absolutely. So many options.
Well, healthcare education is so important. And are you seeing this in our legislation across the state? Is this a potentially long-term change and investment for our state?
Absolutely. In this past legislative session, there were several bills that addressed, what they have identified as the need for more healthcare workers. Our legislators have been very supportive they want to help us. They want to see healthcare grow, and they showed that with the bills that they brought forth during this past legislative session.
And you all are doing a lot for scholarships and a lot of financial and different resources and supports for students. That's correct?
Absolutely. We have grants and scholarships available for students. They can apply to the school, apply to UAPTC, and they can get scholarships for whatever their major is that they would like to endeavor. And so we have lots of scholarships. We also have grants that are available for students depending on their chosen career field. And so if they were just reach out to us to admissions, to financial aid, we can put them on the path to getting and accessing those resources.
And it's no typical student, not just fresh out of high school grads, but could be.
Yeah, it could be, but we have no typical student, Robin. Our students range in age from, like you said, fresh out of high school to we have 63, 64, 65-year-olds who have decided that, they're ready for a change in life and they want to do something different. And so they come back to get that education. So
and all are accredited too. All of the programs are accredited. Yeah.
Yes, our programs are either approved or accredited. Okay. So there's a difference between approval and accreditation. Sometimes a program does not require national accreditation. It only requires state approval. But all programs are either approved or accredited.
Well, Talayia, thank you for talking to me about this. And I hope that the investment that someone makes in their future is a change for all our Kansans across the state for healthcare. Thank you. Thank you for all you do. You're very welcome. I love my job, and I think that this is the best place to be. Well, it shows, and I'm sure that the lives of the students that come across your path are for the better. I know that they are. Thank you. I appreciate that, Robin. Today, I have with me Dr. Andre Paixao. He's a cardiologist with expertise in preventive and interventional cardiology with the Arkansas Heart Hospital. Dr. Paixao, thank you so much for joining us.
Oh, thank you, Robin. Thanks for having me. I'm excited to talk to you about preventive cardiology.
So let's dive right in. Let's talk about educating people on cardiovascular health and what are missed opportunities that you're seeing happening right now.
A lot of people will get counseled on what a healthy lifestyle is whenever they talk to their primary cardiologist or when they seek out this information by themselves online. And honestly, that's the bulk of what you can accomplish as far as minimizing your future risk for things like strokes and heart attacks. But there are certain screening tools that a well-informed patient may choose to undergo. And with that, you can even further improve on your preventive strategies in addition to a healthy diet and lifestyle. Plus, there are a few misconceptions out there on what the signs of cardiovascular problems are and what the ideal strategies to treat things like hypertension, high cholesterol, and things like that would be.
So it's not just about blocked arteries. I mean, it's far more than just that.
That is true. So one of the things that some people come to my office thinking, or at least hoping, is that they can live their lives however they want as long as they catch a blockage in time to prevent the heart attack. And unfortunately, that's not what fits with our current understanding of coronary disease or atherosclerosis, which is the buildup of cholesterol and plaque within the arteries of our body. So it turns out that most heart attacks don't come from a plaque that's creating a fixed blockage, a fixed narrowing on that artery up until the time that plaque ruptures and causes a heart attack. So a lot of our current tools are great at detecting a fixed blockage, a 80% narrowing in the artery that limits blood flow to your heart muscle. That will, in most people, cause chest pain or shortness of breath. And in the ideal scenario, will show up on a stress test, which is what most people get as far as a triage or a screening test. The problem is you may not have any one of those lesions that narrow down the vessel, but you can have a lot of non-obstructive plaque. And those are areas in the vessel where you have a lot of plaque buildup and inflammation. One of those non-obstructive plaques can rupture, a blood clot then develops on top of that, and that's basically what a heart attack is. So just by ruling out a fixed blockage, you're not necessarily ruling out the condition that can lead to the worst types of cardiovascular events. It is important to detect the blockage. We can treat that and improve patients' quality of life, but if the goal is to make people live longer, avoid strokes and heart attacks, what you need to detect is the overall amount of plaque someone has, and then institute the strategies to minimize that plaque progression and reduce the inflammation in that plaque. And those are not treatments such as stents or even bypass surgery. Those are mostly treatments such as a healthy diet, exercise, and medications that will act on the whole vasculature, not just on the segment like a stent would.
So is there way too much focus on blood pressure?
That's also something that I guess some people understand differently than what the current consensus is on the medical community. So high blood pressure is certainly a risk factor for heart disease. If left uncontrolled over the course of months or years, a high blood pressure will increase your chances of developing blockages, of developing congestive heart failure, kidney problems, having strokes, and a number of other things. However, high blood pressure is not a sign of a heart problem. It's not a sign of a blockage. So let's say you go to your doctor's office and your blood pressure is elevated. That does not mean you may have a heart problem or a blocked in your artery. It means you're developing a condition that over the course of many years, if left untreated, can increase your chances for strokes and heart attacks. But it's not by itself a sign of a current problem. And then that causes problems both ways, because it can make people concerned that they have a heart condition just because their blood pressure is elevated, when in fact that's not the case. Most people with elevated blood pressure, even if it's very elevated, don't need to go to the emergency room. They can be treated in an outpatient setting, as long as that's not causing anxiety and additional stress. But also, just because your blood pressure is normal, it doesn't mean you're not having a problem. Let's say you're having chest pain and somebody says you had to check your blood pressure right now, and you check it, it's normal. That can still be a heart attack. It doesn't mean that because your blood pressure is normal in that one setting that it's not something that needs to be looked at urgently. So blood pressure is an important risk factor for heart disease. It does need to be managed aggressively. However, it's not to be seen as a sign of heart disease, and the absence of high blood pressure should not be reassurance that you don't have a heart problem.
So is this something that a PCP should be looking for or addressing for a wellness visit? What do you want those physicians to know?
Yeah, in an asymptomatic patient, I think most of the counseling and screening can come from a primary care doctor's office. So if you see somebody who's concerned about their future for the future risk for things like heart attacks and strokes, a lot of those patients will have a family history of heart disease, or they may have a friend who recently had a stroke or a heart attack. You can start off with what's a traditional risk factor assessment. So using someone's age, sex, blood pressure, cholesterol readings, and the presence or absence of diabetes, you can calculate someone's risk for a stroke or heart attack using models that have been created in this population-based cohort. So you can go online, put all that information in, and it spits out a 10-year risk for things like strokes and heart attacks. And you can use that information to counsel the patient on adopting a healthier lifestyle and sometimes starting cholesterol-lowering medications that will minimize the progression of plaque. If you want to further refine that, you can do a calcium score CT, which is by far the screening test with the strongest scientific data behind it. A calcium score CT is a CAT scan without contrast that's going to measure how much calcium you have in the arteries of your heart. A calcium amount is proportional to the plaque amount. It's proportional to the amount of cholesterol and inflammatory cells that you have in the arteries of your heart. And that's by far the most powerful predictor of your future risk for strokes and heart attacks. Once you have that information, you can go back to one of those models online and add that on top of the age, cholesterol, and blood pressure information. And that gives you a much more precise estimate of someone's future risk for things like strokes and heart attacks. It doesn't mean that person will have a blockage. They may not have a blockage, but they may have a lot of non-obstructive plaque and may still benefit from a very aggressive early intervention program where you're going to have a more aggressive diet, a more intense exercise program. And a lot of these patients probably do benefit from at least low to moderate dose statin, even if their cholesterol readings are not very elevated to begin with.
So when is it time for a patient to see you?
So any symptomatic patient where the symptoms are likely of a cardiovascular nature should see a cardiologist. So anybody with chest pain, increasing shortness of breath with physical activity, swelling in the lower extremities that's not otherwise explained, and sometimes people with sort of palpitations, feeling of racing heart, passing out, or feeling like they may pass out. I guess those would be the most commonly recognized signs of heart disease. So that patient needs a workup that can sometimes be initiated by internal medicine or family medicine doctor, but that those patients usually end up in the cardiologist's office. And the other one is a patient who is asymptomatic but has risk factors for heart disease. So that can be a smoker or long-term former smoker, somebody with a strong family history, somebody with high blood pressure, especially if that's been uncontrolled over the course of a few years, somebody with diabetes, especially if that diabetes hasn't been well controlled over the years. That person may benefit from a more aggressive screening. And some primary care physicians are going to be comfortable getting a calcium score CT and counseling their patients based on those results. But some of them will prefer just to kind of defer that to the cardiologist. So in my practice, I see both. I see patients who just get everything started when they see me, but I see patients that already come with a lot of that data from their primary care offices, from what their primary care is initially recommended. And some of them have been pretty effectively counseled by their primary care physicians even before seeing me. But if someone's primary concern is their future risk for a stroke or a heart attack, I think the most effective way of further improving upon the risk prediction of a regular model is a calcium score CT. I trust that ahead of other tools like a stress test, which really doesn't have much of a role in an asymptomatic primary prevention patient, as well as some of those other markers like advanced lipids, high sensitivity, CRP. Those things have a lower performance in prediction models than a calcium score CT.
And let's change gears for just a minute. Are Apple Watches and personal devices something that the general public should be wearing? Are they screening tools that you recommend?
So as screening tools for atrial fibrillation, which is a arrhythmia that can lead to strokes, they're not very accurate. They probably will get there. That technology is improving. There are studies that have been published, some of them initiated by academic programs, some of them initiated by Apple itself. They're not very accurate when they detect AFib. So you get a lot of false alarms. Plus, you also have false negatives. You have patients with AFib that did not get an AFib alert. I think we'll get to the point where these wearables become accurate enough that they're used in clinical practice. So for that point, I don't routinely recommend an Apple Watch, but I think they're fantastic tools to motivate and to track your physical activity and improve your fitness level. So by tracking someone's heart rate, as well as more advanced metrics like heart rate variability, you can see how hard you're exercising. And it's very, very common that people overestimate the exercise intensity. So they go out for a walk and they think they're getting aerobic exercise, whereas their heart rate barely got above their resting heart rate. So If you're using that tool to monitor how often and how hard you're exercising, I think you can really improve your fitness level, which should further on improve your cardiovascular health. I don't like it when patients are obsessed over their heart rate and on those alerts. I think that creates anxiety without really adding truly useful clinical information. But using a wearable to track your physical activity, even track your sleep time, your resting heart rate, your heart rate variability, I think that's very, very useful in a motivated patient.
So what does Arkansas look like in terms of heart health? Are we in a good place? Do we have work to do?
We're in a good place if you're a cardiologist and want to have a full office. We're not in a good place for public health or from a population-based standpoint. We have some of the worst cardiovascular statistics in the country. We're consistently among the top 5 worst states in cardiovascular mortality. Some of that has to do with the prevalence of smoking. Some of that has to do with a diet, obesity, diabetes, underserved populations. So there's just a ton of work to be done in a state like Arkansas.
What are screening tools that are most useful that you recommend right now, aside from the CT that you mentioned earlier?
So what you get on a regular checkup is already a lot of information. So just by getting a cholesterol panel, measuring someone's blood pressure, checking a hemoglobin A1C to detect diabetes, measuring someone's weight or waist circumference, that by itself tells you a lot about your metabolic and cardiovascular health, and also gives you some targets, some things that you can start working on. Any more advanced testing on top of that, I tend to prefer a calcium score CT on top of other tools that are available out there. But you honestly can know a lot about somebody with a blood pressure cuff, a scale, and a pretty standard lab draw.
Well, it's so important that this starts all the way with the primary care physician and monitoring your own health and really taking it into your own hands on a day-to-day basis. Everything matters.
It sure does.
Well, Dr. Paixao, thank you for talking to me today, and I appreciate the research and work that you do, that you're changing lives across the state, and hopefully we will no longer be in that bottom 5 and move to the top 5 instead.
Hopefully. Thanks for giving me the opportunity to talk to your audience. Appreciate it.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.